this webinar. We probably will have a few other folks join us in a little bit, but I think that probably will be not too disruptive for us. We are keeping the attendees on mute and we'll be taking questions at the end. But let me start off by saying good afternoon, just barely. I'm Gary Harbison, the Executive Director of the Missouri Coalition for Oral Health. MCOH is a nonprofit dedicated to improving Missouri oral health. We are a statewide network of oral health advocates. We raise awareness, engage with community members, advocate for policy change and system improvements, and work together to increase health equity. Please follow us on Facebook, Twitter, and LinkedIn, and through our website. I want to welcome you all to the final of 3 pre-conference webinars for the 2022 Missouri Oral Health Policy Conference, which will be held in Jefferson City next week on Thursday and Friday. You can find more information on the upcoming conference on our website, and we are holding that conference in person. And we're not going to do the traditional Capitol visits that morning, although we do have a few members who are going to do that, take it upon themselves to go up there and do those visits. We're just wanting to be cautious about that with the pandemic still active, and that building, things are a little looser up there than what we'll have in the conference environment. And so we just thought it was probably better to be cautious, not be guiding a lot of people up into the office. However, we have support material if you want to make virtual connection with your legislators. We can help you with that. Thank you very much for being here. Feel free to type questions in chat and Zoom. And as I mentioned, you are being muted. I want to offer special thanks to the Office of Dental Health with the Missouri Department of Health and Senior Services for sponsoring this and the other 2 pre-conference webinars. And special thanks to the Missouri Primary Care Association and Karen Dent in particular for providing CEs for attendees. As you heard earlier, this presentation is being recorded, and we will make that recording available at a later date through our website. We'll also provide a CE code at the end of the presentation in chat and probably verbally as well. And there will be a survey link placed in chat as well as being emailed to registrants. We cannot offer CE for watching the recording though. So if anybody who didn't attend today asked you that, they certainly can watch the recording. We'd encourage them to do that, but we can't provide CE that way. So I'm going to introduce our speaker today for this webinar, Dr. William T. Kane. Dr. Kane maintains a general practice in Dexter, Missouri. He is passionate about recovery and wellness and is very familiar with issues facing dental professionals and patients with addictive disorders. He has served as the chairman of the Dental Wellbeing Committee for the Missouri Dental Association from 1987 to 2016. And he served as a member of the Dental Wellness Advisory Committee with the American Dental Association. In 2013, Dr. Kane was selected by the MDA as Dentist of the Year. He was appointed to serve on the Missouri Dental Board in 2016. He served as president from 2018 to 2019. He currently represents the Dental Board in the Prescription Drug Monitoring Task Force. Dr. Kane co-founded the Smiles of Hope Clinic in Dexter in 2010. The Smiles of Hope Clinic provides emergency dental care for people who have difficulty accessing care. Dr. Kane graduated from UMKC School of Dentistry in 1980, and he completed an MBA at my alma mater, Southeast Missouri State University, in 1982. So please join me in welcoming Dr. Kane. And Dr. Kane, you have the floor.
Thank you, Gary, and welcome everybody. And quite an honor to be here. So start off with a disclosure. I don't have any financial relationships. And then my presentation really doesn't reflect any opinions of the American Dental Association, Missouri Dental Association, or the Missouri Dental Board. So with that, here we go. Opioids and dentistry on point. Couple things that I want to, I think it can't be understated that we as dental professionals, and I'm including dentists, dental hygienists, dental assistants, anybody that works in the dental office, to understanding addictive diseases and opioid epidemic and how that all relates to how we treat our patients. So I just want to, talk about the opioid epidemic, how we got there, a little bit of the history, which is kind of interesting. Want to present the concept of chemical dependency, addictive diseases. I want to present some safe prescribing recommendations. We need to talk about the pandemic, COVID pandemic, and how that collided with the opioid epidemic. And I want to discuss with you how to treat patients that are both in active disease and in recovery. So when I first gave this presentation, a presentation like this from American Dental Association, I had to sign a 17-page contract that said basically I won't do or say anything that might upset anybody about anything. And I said, okay, well, but there's something I have to tell about myself. So I'm going to claim my First Amendment rights. And I'm going to tell you that I'm going to make fun of my religious and ethnic heritage. And if that offends anybody, I humbly ask for your forgiveness. So what you see here is a picture of my father holding me and my grandfather. That's three Williams, William, William, and William. And what you see there are three generations in the CIA. The CIA means Catholic Irish Alcoholics. So if I offended any Catholic Irish alcoholics, please forgive me. So the opioid epidemic, this going back 2015, 2016, it finally became an epidemic. Before that, it was just sort of a problem. And we can't talk about the opioid epidemic without looking at some of the other epidemics and how they are interconnected, intertwined. And that would be the HIV, viral hepatitis, and opioids. And this was put out by the U.S. Department of Health and Human Services back in 2017, which is, now 5 years ago. So now 2020, what do we get? The COVID pandemic and how they collide and how the COVID pandemic exacerbated the opioid epidemic and the addiction and epidemic. So let's bring it back to the show me state for a minute. This was September of 2020, some 6 months into the COVID pandemic. And this said, okay, opioid overdose deaths appear to drop, but the pandemic could erase that. Well, about this at the same time, all Missouri first responders now carry Narcan nasal spray, okay? And this shows an individual, a policeman administering Narcan nasal spray to a patient that's overdosed from opioids. And this is what Narcan nasal spray looks like. And so also about the same time, our Surgeon General came out and said, hey, all healthcare professionals should carry this at all times and use it as needed. Well, my comment is carrying 2 boxes of those in your pocket with your cell phone and your car keys, there's just not enough room for them. I do carry 2 of them in my console of my truck. I have them in my office, and I certainly take them to the Smiles of Hope Clinic, which we'll be at tomorrow. So, drug overdoses and drug deaths are not really anything new. You can go back, 52 years ago when Janis Joplin died of a heroin overdose, Jimi Hendrix, barbiturate, Heath Ledger, and Prince died of fentanyl overdose in 2016. So nothing terribly new. Opioids, has huge impact in our economy. $55 billion a year related to prescription opioid abuse, and $20 million in emergency room department. 20 billion, that's a bunch of money. So what's the missing piece of the puzzle in the opioid epidemic? Everybody talks about big pharma and Purdue Pharma making all the OxyContin and all the, here's the missing piece of the puzzle. the person that is using the opioid product. Now, Journal of California Dental Association, March 2019, came out with this journal dedicated to the opioids, trying to navigate the perfect storm. And I wrote an article here, and in the yellow circle here, basically what I said, the part is missing from the opioid epidemic is how the person taking the opioids, how they react in this. And I submit to my dental colleagues, if you've got a patient with an opioid addiction or any kind of addictive disease and it's untreated, whatever kind of dentistry you do for them is going to fail. And so here's, still startling statistics that about 142 people per day die from opioid overdoses. And that's a bunch of people. And this can be prevented. And so, and we're just kind of stuck on this screen here. There we go. Just something here. This is showing just drugs that our patients are taking. In the gray is the harm to the user, and in the yellow is a harm to others. And of course, alcohol, heroin, crack cocaine, methamphetamine. Obviously, these are bad for the user. And you get down to tobacco and marijuana. These are the drugs our patients are using. And I'm going to move through this kind of quickly here. Here's something, probably one of the most important slides I can in this whole talk, is the prevalence of substance abuse is so high that every healthcare provider in the United States sees patients either at risk or expecting negative effects of substance use by a friend, family member, or coworker. Probably everybody I'm talking to, everybody's hearing my voice right now, probably knows somebody, a family member, a friend of a friend, a friend of a coworker, that has been affected by an addictive disease, whether it be alcoholism or drug addiction. Now, this came out in the 80s. This is these little articles were put in Dental Economics and Partnership of Drug-Free America, and they're way ahead of their times, way ahead of their times. And here's a picture of the dentist with blinders on. Drug abuse in my practice? So I'm giving this presentation one time, and there's a gentleman about 3 rows back sitting there all in a negative posture like this. And I showed this slide, and he said, I don't have any addicts in my practice. I said, oh, really? You don't? And I said, well, doctor, do any of your patients smoke? Well, yeah. I said, doctor, you have patients that are nicotine addicts. Oh, okay. So, I think we as dentists sometimes want to, see no evil, hear no evil, look at no evil. So in dentistry, we got a black eye in July of 2009 from this guy, Kenny Morrison. He was all over the airways talking about how he was scamming dentists for hydrocodone. He was at one time a chef to the stars. However, he got his drug of choice, hydrocodone, not on a street corner, not from a dope dealer, not online. He got it from dentists. And that was back in the day. He would call some dental offices in Los Angeles at 4 p.m, 4:30, feigning a toothache and saying, well, I'll get this horrible toothache and I can come in tomorrow, but can you call me in something to get me by through the night? And apparently he was quite good at it. This was getting really a whole lot of publicity, but the thing that took the heat off of us there was Michael Jackson died. Well, Michael Jackson died from a propofol misadventure. And so that was in the summer of 2009. In the spring of 2010, the Tufts Healthcare Institute had a program called Program on Risk Management. And they invited in a bunch of dentists from academics, from the American Dental Association and government. And we had a meeting at Tufts University School of Dentistry. And I got to go. And it was amazing. I was the only dentist in the room that didn't have PhD behind my name. Everybody else there were DDAS, DMD, PhDs, chairman, professors. And out of this, we recognized there was an issue with opioids. And the issue with the opioids was worked through, and we, out of that conference, came up with this article, Prevention of Prescription Opioid Abuse and the Role of the Dentist in 2011, which is, that's 11 years ago coming up on. And so we've been kind of circling this issue now for 11 years. And we also came up with another same article in the compendium. And one of the things that they came out of was they wanted us to avoid a recommendation like when you take out a tooth, you need to give 12 hydrocodone 325s. Well, they wanted a clear cut, and there's no clear cut to anything in dentistry. Not one size doesn't fit all. And having said that, in this month's JADA, February of 2022, there's been a small survey of about 291 dentists, and one of the things they want more than anything is more education, which is we started back in 2010, 2011. But they also want more clear-cut prescribing guidelines, and we'll talk about that later on in the program. So also at this time, 2011 was a white paper came out from the White House about prescription drug abuse, and Gil Kilikowski was the drug czar. He came to the American Dental Association Wellbeing Conference and basically said, hey, man, we need your help to kind of get this opioid epidemic, this opioid mess cleaned up. It was really kind of neat to see that. Interestingly enough, that our first article in the JADA has been referenced in, like this came out in September of 2020 from the Bayer company in regards to non-steroidal anti-inflammatory pain medication. They still cite that article. So that's kind of a classic article about pain. And this is when we first began to discuss and espouse the use of acetaminophen and ibuprofen as analgesics that were equivalent to opioids. So one of the things that I learned at Tufts was this. She gets her hair from her mom, her eyes from her dad, and her drugs from her parents' medicine cabinet. So back in the day, when we were prescribing 20-25 hydrocodone, it really never dawned on me that all those pills would have been left over in somebody's medicine cabinet until I went to this. And I'm like, okay, 2x4 between the eyes, Missouri Mule. Yeah, these are left over, and these are how this generation is beginning their drug use. Where back in my day, it was sneaking a beer, drinking a beer behind a quick shop, smoking a joint behind the quick shop. Now they're a little more sophistication and sort of more justification to, well, I got these from grandma's medicine cabinet or grandpa's medicine cabinet. They're medical grade, they're pharmaceutical grade, so I'll take one. If you want to read more about the opioid epidemic, read Dreamland by Sam Quinones. It kind of talks about the opioid epidemic way before even the dentists were involved in 2010. Very good book. The book on the right is by David Sheff. His son was suffered from an addictive disease, and David was a journalist. This is the best book I have ever seen, and I've seen dozens of them on addiction and just the hellish aspects of addiction. It's written very unbiased. It's very neutral. And I would recommend, if you have anybody that you know that has an addictive disease, read this. It gives you immense understanding. And here's some really good books in terms of clinical prescribing opioids, and they're kind of a classic. And I'll just throw that out for. This is a really good book. This is put out in 2015 by the ADA, and there's a chapter in there that I authored on the impaired dental professional. And as Gary said, I chaired the Missouri Dental Association Wellbeing Committee for almost 30 years. And I'm here today because Missouri Dental Association saved my life back in 1984 when I was suffering from an addictive disease. It was an opioid. And as chairman of the Dental Association's Wellbeing Committee, I've been able to assist hundreds of Missouri dentists, dental hygienists, staff members, and people from all walks of life in their journey in recovery. So I truly understand this. It's been a great thing personally, professionally, and I treat a lot of patients that are in recovery from this. So this is a great book, and it covers just a great thing. And the second edition, I think, will be coming out in a few years. Another great book, and not because I'm in it, but this is a great one. This is about the opioid epidemic. Now we're in Weed by Ben Court. This is the greatest book I've ever seen on marijuana, barring none. The marijuana out there right now, the street marijuana, is not the marijuana from my generation. My generation, those of us that did inhale, probably at most the tetrahydrocannabinol content was maybe 16, 17%. And now some of the medical marijuana is up in the 80s and 90% of THC. So it's a wholly different game. So how about marijuana in dentistry? And I'm talking about opioids, but they're kind of like marijuana is kind of edging its way into the opioid picture. And I'll talk about that here in just a minute. Medical marijuana now is legal in Missouri in 2018 and became first licensed sales in 2020. There is a medical marijuana dispensary in Dexter, Missouri. It's open 9 to 9 Monday through Saturday and noon to 8 on Sunday. There's medical marijuana dispensaries in all the little towns around Southeast Missouri. I have about a dozen patients that are now owning up to using medical marijuana. And that's very interesting because, our patients are using it. If I've got 10 or 11, 12 patients telling me they're using it, I probably got some that are using it and aren't telling me. And, marijuana and opioids, Colorado was one of the very first states to legalize medical and recreational marijuana. And one of their big claims to fame was Colorado had one of the lesser overdose and lesser problems with opioids. And here's some literature from various sources that said, well, yeah, there's less dependence and fewer opioid deaths. And, having said that, cannabis appears to increase rather than decrease the use of developing an opioid use disorder. And I would say that's a very valid statement. And more literature supports the possibility that cannabis may prime the receptors for addiction. And it's well known in the addictive medicine community that marijuana is a gateway drug to other drugs. And I think that's been very well documented in the literature. So, if your patients are using marijuana, they could be more susceptible to addiction to other things. We'll talk about that further down in the program. Now, one of the things that I've noticed here is, okay, I'm a dentist, and what is concerning me about patients with medical marijuana is, okay, what do we use every day on our patients in a general dental practice? Local anesthesia and nitrous oxide, and occasionally some benzodiazepines orally. Back in 2016, when we started talking about your patients about marijuana, one of the things was, well, tell your patient not to smoke any dope for a week before they come in, and because it could affect the anesthesia and risk of infection is high. Well, that might as well be like talking to a tree. If they're going to smoke, they're not going to, if they're a regular smoker, user of marijuana, they're not going to stop for a week. And I'm just saying that. So local anesthesia, it says could promote anesthesia. It could be, if it isn't, then it could be some deeper desensitization. What we don't know in medical marijuana or any of the cannabis, there's about 100 different cannabinoids, different psychotropic molecules that we don't really know that much about. It's not like a USP where we know aspirin 325 milligrams has 325 milligrams of acetylsalicylic acid, or diazepam has 5 milligrams of diazepam in it. We really don't know what is in this. And so I was concerned about that. And it says marijuana users appear to have intensified subjective effects induced by nitrous oxide. And I would say yes, no, maybe. Back in the day when I was treating heavily marijuana, people I'd see smoking marijuana in the parking lot before they came in, or I could smell it on them. You put the nitrous mask on and get them up to 50%, and they go, hey, I'm not feeling anything. Well, you're stoned. So This Journal of Alcohol and Drug Dependence, again, is quite old, says there's no difference. And I think there's a whole lot more out there that needs to be looked into on this. But having said that, medical marijuana in my practice, probably of the, let's say, dozen patients, 9 of them are using the edibles or the gummy bears or the gummies. And the other 3 are vaping it or smoking it. So something in the ADA News a couple of weeks ago was talking about, okay, the vaping and how that was bad and smoking. And we pretty much understand that. We have no problem with that. The problem being with the gummies, they got sugar in them. And I had a patient in the other day who has been on opioids, high dose of opioids for chronic pain for prostate cancer. And he came in the other day and he had gummies all over his teeth. He's got a whole bunch of other comorbid things, but he did say, since he's been doing the gummies, he's using less opioids. So good, bad, I don't know. I mean, that's just it. The other patients, all these patients are in their late 60s and 70s. And about half of them I would have never thought would have been using medical marijuana, but they are. And these are long-term patients I've taken care of for more than, say, 15 years. We've actually lost more patients to the opioid epidemic than were killed in the Vietnam War. And it's just a huge increase, and it's not going the other way. Now, the game changer for us was 2014 when hydrocodone became a Schedule II narcotic. So therefore, you couldn't call it in anymore. And I asked a pharmacy one time, I said, so now that hydrocodone is Schedule II, what do you think is going to happen? And the first thing he said was there's going to be a whole lot less people allergic that aren't allergic to codeine anymore, because you can still call that in. So this has been a game changer for us in dentistry. And are we the new targets? Yeah, we were, we are, we still are. And, the opioid zealots are like anti-vax people and people that are opposed to various causes. I don't think we should, prescribe opioids. And I think as dentists, we're treating patients, and we know we kind of get a handle on what we're doing to, for, and with our patients. And if they need an opioid, I think opioid prescribing still has its place. Certainly, I prescribe less opioids than I did 25 years ago, but I prescribed opioids this week. So here we go. We dentists prescribe 15.8% of all opioids. And back in the journal that just came out, that's the new number. And they're saying, hey, we need to really revisit our prescribing habits. We just really got to get it together, guys and gals. Real quick, hydrocodone is 6 times stronger than codeine, and oxycodone is 12 times stronger than codeine. And these are well known to be gold on the street in terms of street value, selling these pills on the street. And we're, of course, in dentistry, we're using the immediate release, not the extended release like Oxycontin and so forth. But these gives you an idea how potent these drugs really are. Now, back, 2018, Dr. Harbaugh, research physician at University of Michigan, put this long-term study of 70,000, almost 71,000 patients in the Journal of American Medical Association, where she looked at these patients 18 to 30 with commercial insurance, underwent wisdom tooth extraction. Of course, we know wisdom tooth removal is kind of the rite of passage from youth into adulthood. And yet, when you look at who you're targeting, a lot of the first time they've had an anesthetic in terms of IV or general anesthesia, and it's the first time they've had an experience with an opioid, with hydrocodone. And her comments, this is a good study, said, opioid prescribing increased the risk of developing opioid dependency 2.7 times. And prescribing opioids for routine dental extraction should be avoided. Well, this also got all over the news, got over the Chicago Tribune, got on the TV, and it said we're prescribing, and we're making addicts. And there, Lester Holt had one on there. The young gal got her wisdom teeth removed and got a 60-day supply of Percocet. And when that ran out, she started shooting heroin. So, and then this came out. Would you give your child heroin to remove a wisdom tooth? And this was in Times Square on the billboard. But if you go back to our pre-dental years in organic chemistry and you look at these benzene rings, I call them hexylmethyl chicken wires. If you look between heroin there on the lower right, hydrocodone and oxycodone, the structure is very, very similar. You've just got a few HC3s and CH3s, I think they call those methyl groups, that are different. And so this got a lot of attention. I had mothers, say, well, I don't know if I don't want my kid to become a heroin addict if they get their wisdom teeth out and that bad oral surgeon gives them an opioid. So, heroin, opioids, heroin is an opioid. It's very readily available. It's very inexpensive. It's readily available. Heroin's readily available in Dexter, Missouri. And if it's available in Dexter, Missouri, it's available in any little town in the US. They'll deliver it to your place of business, to your house. They'll take cash, but also you can swipe your debit card on their cell phones or your credit card. So, if you're addicted to alcohol, you're 2 times more likely to be become addicted to heroin. Go all the way over to opioid painkillers. If you're already addicted to opioid painkillers, you're 40% chance, times greater that you'll be addicted to heroin. And I do have patients that I know, people that I know in AA and in my recovery circles, that when they couldn't get hydrocodone or oxycodone from their dealer, they used heroin. So very much out there. Okay, so what are we going to do to prevent the heroin epidemic, the opiate epidemic? And I'm using the word heroin here on the slide, but opioid, you could change it to opioid. Prevent it. We want to reduce prescription opioid abuse. We want to reduce addiction, and we want to reverse overdoses. Okay, that's why we're carrying Narcan nasal spray. If somebody does overdose, and you can buy Narcan over the counter at the pharmacy, no questions asked. They call it the safe drug, the safe drug. And the sophisticated opioid users know that they need to have the opioid reversal agent handy, and they use it. So taking that to the role of science in addressing the opioid crisis, and of course, one of the most respected journals in medicine, the New England Journal of Medicine, great peer-reviewed journal, they echo the same thing. It's really kind of hard to see here, but it kind of in reverse order. They've got overdose prevention and reversal at the top. In the middle, they've got treatment of opioid use disorders. And then at the bottom, they got treatment of chronic pain. And we're going to go into chronic pain and opioid addiction and how those overlap and how those affect our patients here in just a little bit. So fentanyl, carfentanil. You turn on the TV, you hear fentanyl. Well, fentanyl's out there, and we believe it's coming from China. We believe it's coming from China through the southern border, and we don't know what's in the fentanyl. Fentanyl is 100 times more powerful than morphine, but then your carfentanil and your sufentanil, which are some of the designer drugs, ones that are made in a lab, we don't know what they are. And I've had a first responder tell me he was in St. Louis. He was a highway patrolman, and apparently somebody had some kind of heroin fentanyl overdose, and it took 4 Narcan nasal sprays to bring the patient back. He thought the patient was dead, and it took 4. I've also heard anecdotal reports of people, taking 5 and 6 Narcan nasal sprays, and they don't come back. So fentanyl is in marijuana, fentanyl is in heroin, and it's a very horrible drug. And this article was written in 2020 from the University of Missouri about our fentanyl problem. And really, when you peel away the layers of the onion, when you're looking at an overdose death, and if you were doing a really extreme toxicology, if it's opioid, there's probably going to be a fentanyl component in there. The Journal of American Dental Association in the last several years have put several articles about opioids. These are on the front page. So, we've been there, we've kind of done that. we're making an attempt. Can we do better? I think so, but better than nothing. So how do we respond as dentists to the opioid? I think we need to recognize there is an epidemic, and not just like the guy that I showed you earlier that's got the blinders on. We need to understand that, yeah, it's out there. Just, we had to understand and grasp the COVID pandemic. I mean, 10 years ago, we heard about the flu and swine flu and H1N1, but COVID was a game changer. So we really need to understand addictive diseases in our patient population. And I think this is an area we can always improve upon. We need better education in dental school, and we need better prescribing practices, and we need to understand both acute and chronic oral pain. Interestingly enough, in the JADA article that just came out, it said 79% of the dentists surveyed of a 291, which is a small sample, but nevertheless it made a peer-reviewed journal. 79% of the dentists said that training they got in dental school on prescribing no longer fits today's practice models. And I would echo that, since I graduated in 1980. What I learned in 1980 is not appropriate for what's going on in 2022. So I think we need to understand and be able to address pain management in our patients, both that are active disease or in recovery. I think we need to know what's going on in our communities about the opioid abuse, and I think we need to have available appropriate referrals. When a patient comes in, we take their blood pressure when they come in for recall, or we're going to take a 2000, the blood pressure is 220 over 115. We think nothing of telling that patient, hey, you need to go see your primary care provider, and you got some hypertensive issues, or the hygienist sees the patient and the gingival tissue's bleeding, and we can't, have you been to see your primary care provider? Have you had any blood, is it diabetes running in the family? We kind of do that. And I think most dentists don't have the ability to say, hey, Fred, I'm really concerned about your use of this substance. And we need to send you down to see so-and-so. And I think we as dentists and dental professionals are uncomfortable with it. Now, if there's hygienists here, the hygienists have the unique ability, I believe literature shows that of all healthcare professionals, dental hygienists spend the most nose-to-nose time with a patient, developing rapport. They're talking about preventive care, about brushing. They know about their family and this and that. I think we really need to ramp up in dental hygiene education and even dental assisting education. More educational processes about addictive diseases and so forth. All right, so different types of pain. We deal with inflammatory pain, noxious stimuli pain, but there's also multiple other pain, neuropathic pain. Patients post-herpetic neuralgia, fibromyalgia, irritable bowel syndrome, chronic pain syndromes that we maybe don't quite understand as dentists and need a little bit more training to get kind of up to speed. And so getting back to pain now, back in the day, the fifth vital sign was pain, and whatever the patient said the pain was what it was. And it justified a lot of overprescribing of opioids without really adequate diagnosis and treatment plans. So, the fifth vital sign came in the 90s and it departed in 2016. My brother, who worked in the hospital industry during that time, he said, Bill, I think one of the things that's driving the opioid epidemic are patient satisfaction surveys. And he started in the hospital business in the late 80s. And he said by the 90s, and of course you were probably, all of you've gone to the emergency room and back in the 80s and 90s, and you got a survey in the mail, or how was your experience? Rate us 1 to 10. Patient satisfaction, and of course, the managers were like, oh, we got to have happy patients. Well, happy patients were patients that didn't have a lot of pain. So I just thought that was an interesting comment from my brother. That's his opinion, and it may or may not hold water, but anyway. So the fifth vital sign in 2016 went away, and that was the 1 to 10 score. 10 was like you got shot in the heart with a bazooka. 1 was when you got a little owie on your finger from, bumping it on the countertop. Now, this was also about the same time, 2016, 2017, when opioids had reached the epidemic, and the opioid crisis became the opioid epidemic. And we became also opioid phobics and anti-opioid folks, and the pendulum swung the other way. So, really interesting to find out that most patients think we sincerely care for our patients, and we do. But how do we feel about pain, and how epidemiological study on dental pain is really quite scarce. And interesting enough, in the JADA article that just came out last month, one of the things is about how we feel as dentists about pain and providing adequate pain care for our patients. I think this is kind of like the cat or the dog chasing its tail. We're chasing our tail. We chase it one way, then the other way, and we probably need to kind of stop and really look at this and look at our prescribing habits, look at our patients, and look at what's going to be for the best good of the patient. So, and a lot of the literature, the majority of the research pertains to children in pain. And, there are also, I can remember back in the 80s and 90s when, I can remember when in the early 80s when they were saying prescribe Quaaludes for, anxiolysis. And of course, then we went through the thing with the sleep dentistry and the conscious oral sedation and IV sedation. And, I can remember going to one continuing education where they're talking about prescribing, barbiturates, Seconal. And this was before, a lot of the state dental boards had regulations on conscious oral sedation. So we've been all over the map with kind of indiscriminate prescribing of controlled substances, whether it be opioids, Dr. Feelgood. I remember Elvis Presley's dentist was known as Dr. Feelgood, and he was prescribing Elvis Percodan back in the 70s. So, this isn't anything new. So, because there has been a dearth in the literature, we need to really look at our practices again. And again, we're revisiting this again in 2022, and we really started the visit in 2010. And back in 2013, which is quite some time ago, we started seeing substance use screening and intervention in dental practices. And what we're finding out now that about maybe 77% of us ask that in our health history, but some don't. And they're saying now the younger dentists are more likely to ask about that than older dentists like me. Well, and that's true. And when you think about some of the things that have come and gone, we think of the human papillomavirus, and you think of, we're supposed to discuss human papillomaviruses and sexual practices with our patients. Well, some are going to do that, and some aren't. And I think really the literature shows that we as dentists are kind of ambivalent when it comes to the risk mitigation of this. We're kind of on the fence. We're either going to go, we're not going to do it, or I'm going to do just a little bit of it. And so 75% of the dentists always ask about alcohol or substance use prior to prescribing opioids. Okay, that means 25% don't. 78% of the dentists routinely discuss interaction between benzodiazepines and other drugs, yet only 50% often or always use their state's PDMP, which is prescription drug monitoring. Now, we don't have one in Missouri. We have it on the books in the law, and I'm on the task force now. We're putting that together, and hopefully that will be available in January of 2023. I think that's going to be a game changer once we figure out how it's going to work and convince the dentist of Missouri that they need to use it for the benefit of their patients. And again, 54% of the patients reported that pain management education they received in dental school no longer aligned with current. Just latest right off the press, February 2022. So I want to talk for a minute about, we're kind of going into addiction, and I'm going to kind of fly through that. the broad term is chemical dependency, kind of like TMJ. Okay, TMJ, is it a disc? Is it a meniscus? Is it a disc? Is it myofascial? Or heart problems? Is it valve? Is it AFib? So taking the broad topic of chemical dependency, substance use disorders, the latest thing they're calling in DSM-5, abuse dependence, alcoholism, addictive diseases, drug addiction, nicotine addiction, and these all qualify for the term chemical dependencies. And patients bring these into our office. And they bring these in: gambling, eating disorders, sex compulsivity, problematic internet use, etc. Now, yesterday or the last day I was in the office, I had a patient on nitrous oxide, and he was trying to text while he was on nitrous, while I was turned around doing something. And I'm like, okay, we have the sign in the office, please don't use your cell phone. You've all had those experiences. I'm doing an endo on a patient one time with a rubber dam. Her cell phone rang. She handed it to my assistant, said, answer it. Yeah, we're all, and I think present company included, I have a greater dependence on my cell phone than I probably should have. But the cost and the prevalence is, again, just astronomical. And it's coming into our practices. Again, there's the same slide. We know that, and these patients are bringing that in our office. Now, what are the risk factors about genetics, gender, mental illnesses, healthcare professionals? Addiction is an equal opportunity disease. And I can tell you, I know of 3 dentists that began their journey in recovery were homeless. These were dentists that had practices, had families, and due to their chemical dependency, their drug addiction, their alcoholism, lost everything and were homeless. And I can tell you, 2 of the 3, well, all 3 of them ended up going back into dentistry, and 2 of them did extremely well, 1 did not. So addiction is an equal opportunity disease, and it has to do with a lot of these factors right here. Why do we use? Well, the list goes on: to escape, feel normal, celebrate, medicate stress, on a dare. Everybody else is doing it. So again, Partnership for Drug-Free America. This is your brain. This is your drug. These are drugs. This is your brain on drugs. And this slide is way ahead of its time, because look at National Geographic. You'd think there'd be something on there about your rivers in Kenya, but they have the thing on the science of addiction. What are they showing? The brain. Well, the brain is where the organ in the body, where the addiction, like other diseases, it's the target organ. Now, it's preventable, it's treatable, it changes biology, and if untreated, can last a lifetime. And the American Society of Addiction Medicine lists this as their definition: primary chronic neurobiological disease with genetic, psychosocial, and environmental factors characterized by one of the following. And that's spot on. That's good. Now, it's a chronic disease with relapse rates similar to hypertension, diabetes, and asthma, but look at the yellow there. It can be fatal if not adequately treated. So in circles and treatment circles, it said, okay, you got 3 choices with your addictive diseases: your alcoholism, your cocaine addiction, your opioid addiction. You can recover, you can be institutionalized in a mental institution or a jail, or you can die. And you look at the chronic disease, it's the only chronic terminal disease that the patient has complete control over how the outcome is. So, if you get a cancer, certainly you can do everything you can, but you got to hope the chemotherapy, the radiation will get you through to beat the cancer, to be a survivor. And in drug addiction treatment, alcoholism, the patient does the treatment appropriately, they have the control and the outcome of the disease. And I have seen way too many people die of this disease that I care to even think about. And I think addiction needs to be looked at as a chronic disease rather than an acute disease. And in medicine right now, I think we're kind of looking at addiction as more of an acute disease. And that's kind of like us in dentistry saying, okay, you got type 2 perio. Hey, we're going to clean your teeth and you'll be fine. No, that's a chronic condition. You got to do a lot of stuff to get you got to do a lot of treatment to get things in the right head in the right way. Nora Volkow, the lady that ran National Institute of Drug Abuse, said it's the neurobiology of addiction, of behavior gone awry. Mental mismanagement, denial, and terminal uniqueness and isolation. Well, mental mismanagement means instead of taking your paycheck to pay the rent, you buy cocaine with it. Or instead of getting a designated driver to drive you home or have somebody come and pick you up or take a cab home from the bar, you drive home and have a wreck. Because, denial is you deny that you have the problem. And terminal uniqueness is, if everything in the world is out of step except me, and if the world would do what I want, everything will be fine. And isolation is what has exacerbated addictive diseases during the pandemic when we had to lock ourselves down. And this shows again where the brain hits the neocortex, the amygdala, and it's your pleasure center. It's the it's the chocolate sundae. It's the puppies. It's just wonderful. It's a dopamine surge. And that's what opioids do to the opioid receptors in the brain. And it's very complex and it can be explained. This is the DSM-5. It's the Diagnostic and Statistical Manual of the American Psychiatric Association, where they're making a diagnosis of a substance use disorder or an addiction. And you can see their withdrawal tolerance. If you got 2 of 3 of those, you have a moderate substance use disorder. You have 4 more, it's severe. And this is kind of like, classifying perio. So many 4 millimeter, 5, 6 millimeter pockets takes you from class 2 to class 3. And this is denial. It's not the river next to the pyramids in Egypt. And patients that are using opioids, using drugs, are in denial that they have a problem. And they will, after you confront them about it, when they're really good early in their disease, they'll make it think like you've got the problem. So here's a couple books where they talk about the neurobiology of addiction, the science of addiction, and I read these, but they're very difficult to understand. But this is where we're headed in addiction. And I say there's 3 diseases that start with A that we don't know that much about yet, and we're still learning. And one is autism, one is addiction, and one is Alzheimer's. So, and they all affect the brain. So this is a book from the American Society of Addiction Medicine. This is like the Harrison's internal medicine book, the Bible of internal medicine. This is the Bible of addiction medicine. It's got everything in there from A to Z. And now they're talking about vaccines. Of course, we're hearing a lot about vaccines for COVID. And we've been hearing a lot about vaccines now for years on substance use disorders. And word is that they don't feel this is going to be a very lucrative proposition for the pharmaceutical companies. I beg to differ with them. I think it'd be huge. And it's planned for cocaine, nicotine, heroin, and methamphetamine. And so how do we identify our patients? And we have low risk, at risk, problematic, and addiction. We have non-users. We have certain people in certain religions and cultures that don't drink. We have low risk people occasionally drink a beer, smoke a joint. We have misuse. Maybe they're abusing, which what most college students do, and then addiction. So this is all happening in the brain. And if you have that genetic predisposition in the brain, like I did, when you add the drugs, the alcohol, it's like, it's kind of like if a parent, a mother and a father, were anaphylactically allergic to penicillin, and they had a child, and they took the child to the pediatrician with an ear infection, and the pediatrician said, is anybody in the family anaphylactically or allergic to penicillin? And they said, yeah, both mom and dad and I are allergic to, anaphylactically allergic to penicillin. I think the pediatrician would probably think of maybe another drug of choice for that. So, if you get that genetic predisposition there, you're off to the races. And here's the chemicals that we got to deal with. I mean, this talks primarily opioids, but if you're using opioids, you have used or you also are using um, alcohol, nicotine, caffeine, uh, benzodiazepines, um, designer drugs. So, these are the list of drugs that our patients bring in that can be problematic. Now, how about this one? As your dentist, I would recommend Viceroys. Okay. Um, Now, Michael Glick, the editor of the Journal of American Dental Association back in 2005, threw this out to us. He said, not discussing smoking and tobacco cessation with our patients who use these products is not an option. And okay, so yeah. How about this one? This was in the Journal of the American Medical Association, March 10th, 1952. That was the day I was born. And, a doctor smoking a Camel. Okay. Here's something to think about. And I'm going to spend a minute on this and see how that kind of ties into other addictions. It's the most common chemical dependency in the United States, whether that's smokeless or smoking. Um, it's regarded as a pediatric disease because kids also begin smoking, trying tobacco at a very young age. And generally, the public is aware that tobacco is harmful, yet they underestimate it. And generally, I think, patients can think, well, I'm addicted to nicotine, or I can't quit. I mean, so that may be your foot in the door to begin a discussion with a patient about an opioid misuse problem, an alcohol misuse problem. Now, here's something to consider, and I think this is something we as dentists and hygienists, we see this. We see the ravages of tobacco use in the oral cavities of our patients. In the United States, medical and dental professionals have traditionally viewed tobacco use as a risk factor instead of the primary problem. This has impeded rather than promoted the development of optimal treatments for nicotine-dependent patients. Now, I know some orthopedic surgeons in the St. Louis area that will not do a knee replacement, hip replacement, shoulder replacement on a patient who's smoking. You got to quit smoking before you're going to do it. I know some periodontists that don't do implants on patients that are smoking. Well, obviously they've had some bad results, and understandably. Now, my question there is, well, they quit smoking, get some implants, get a knee done, they go back to smoking. That may or may not be good. But I'm simply, this is kind of a out of the box thinking, kind of a challenging, kind of out there, leaves you more questions than answers. But I did have a patient one time that was smoking 3 to 4 packs of cigarettes a day. And he said as many times as he's tried hypnosis, he's tried all the Nicorette gum, he's tried the Shantex and he said, the only way I'm going to quit is I've got to go to a treatment. I'm going to go to an inpatient smoking unit. And there are very few of those in the United States. So having said that, I've said that. It's just kind of interesting, something to consider. Now, if you suspect chemical dependency in your patients, how do you broach that subject with a patient? Well, the CAGE questionnaire, the screening brief intervention, referral to treatment, SPRIT, and referral information. I'll go through that kind of quickly. The CAGE is real simple. I've got it on a little Post-it note in my office, and it's, have you ever tried to cut down on your drinking? You feel annoyed when people talk to you about your drinking? Are you guilty? You have to have an eye opener. Well, 2 of those indicate, yeah, probably you might be and 3 or 4, you are have a problem with whatever substance, opioids. And, breaking that subject with a patient, if they smoke and they're bristled up, they don't want to hear about it. You say, well, Mary, you smoke, right? Yeah, well, Mary, would you agree you possibly have a problem with addiction, dependency on nicotine? Yeah, well, Mary, it's very possible you could be, here's a little test. And screening and brief intervention and treatment, UMKC has that, School of Dentistry has that online. It's very good. And it takes you through the 5 A's. You ask their readiness to change. And you've also had patients say, I don't want to hear anything about me. Don't even talk to me about not smoking. It ain't going to work. We've all had those patients. But, maybe at some time, if you see the patient again, you can, kind of get your foot in the door. And you can kind of say, well, gee, Mary, I understand you're in the hospital. You missed your last appointment because you're in the hospital with pneumonia. Maybe it's a good time to think about quitting smoking or quitting drinking or, whatever. Mary, you fell down and broke your arm and you were intoxicated. Maybe this would be a really good time to think about, getting some treatment. The best medical advice I ever got was from my dentist. I mean, and okay, so, we've got to look at our patients and say, okay, whatever dental treatment we're doing, whether it's all on four implants, full mouth rehab, full mouth veneers, scaling and root planing, if you're doing it on a patient that's using it's not going to work. So if you get a patient into treatment and you're transforming into recovery, it usually requires some sort of intervention. They just don't wake up one day and go, I'm going to treatment. It's usually a DUI. It's, the three L's: liver, lover, and laws. Liver's going bad. You're in trouble with the law, or, your significant other says, if you don't quit drinking, using, I'm leaving you. So it does involve an intervention. If you've ever seen Intervention on A&E, it's a great show. I'd highly recommend you look at it. It's very realistic, very, very realistic. An addiction is a family disease. Everybody in the family is as sick, if not sicker, than the addict, him or herself. And having grown up in a family with an addicted parent, I can tell you addicted families are highly dysfunctional. And we treat those patients in our practice, whether that be the mother, the wife, the children of these. And so, what is treatment? Treatment ranges from A to Z, from do-it-yourself to the Minnesota model, to medically assisted drug therapy, to mutual help organizations. And the stack of books here on the right, I got it at Barnes and Noble, and those are How to Quit Drinking for, like, for complete idiots, and all these things. And I tend to be more biased towards formal treatment for self-help and the faith-based. I've anecdotally have not seen a great deal of success with do-it-yourself treatment models. And recovery is very complex. So if a patient comes in and they say they're in recovery, it does require intensive efforts. And someone that is a grateful recovering addict, I can tell you that it's a daily reprieve. It's just more than stopping. It's not detoxing. And when I hear the word cured, former, recovered, past tense, or X, they're not appropriate. Or the one that drives me absolutely crazy is, this is what they say about the Hollywood folks: they beat addiction. Would they beat it with a ball bat, tennis racket? And the relapse is inversely related to the duration of recovery. And I think this is something we need to know, just kind of like we know when a patient comes in and just had 3 heart stents. Obviously in the first 6 weeks after 3 heart stents, their myocardial status is a little less stable than it would be maybe 6 months hence. So, when somebody comes in and reports a recovery, I think you need to know the duration and how the recovery is going. And it's a one day at a time, a lifetime commitment for the individual and the family. And having been involved with hundreds of dentist families, I can truly say this is it. And it's heartbreaking when you see the addict or recover and the family doesn't. And that happens, and it indeed is a sad situation. But these are the patients we're treating in our practice every day. So when your patient has an addiction, I'm going to run through this. What's an addict look like? Well, look like one of these guys or gals, that passed out, or, but this is my favorite. This little guy looks like he's token up there. Or a dentist, a nurse, pharmacist, chiropractor, anybody. I mean, it's an equal opportunity disease. And actually, our healthcare workers are probably at a higher, literature shows they're at a higher rate of incidence than the general public. Many of our patients will be in active disease, some will be in recovery, and we as dentists are every bit as the risk of developing a substance use disorder, behavior, mental health disorder as anybody else. And I know a lot of dentists that have mental health issues, that are depressed, that are not getting adequate treatment, and they're working on their patients. They're going through life, just muddling through life. So here's something that's really kind of thought-provoking again, kind of like the nicotine thing. Properly addressing the health needs of an addicted patient requires the skills of a specialist in addiction treatment, skills that neither ethicists or most dentists possess. Well, when you first start out in practice of dentistry or dental hygiene, you know it's to make you safe, beginner, or I say it's to make you dangerous, ha ha. But we learn over time, how to treat patients with complex medical conditions. We learn how to treat patients with mental health issues. And this is something, these patients come to us and they're difficult to treat, just like somebody on chronic pain or somebody with artificial heart valve. So about 3% of the ones you're going to identify, okay, smell alcohol in their breath, they're scamming you for drugs. But about 97% can be still functioning alcoholics and addicts, and these are the ones that are going to drive you crazy. And so when you start, how do you do this? When you start your patient interview, if they start listing suspicious drug allergies, I'm allergic to Darvocet, I'm allergic to Tramadol, I'm allergic to codeine, I'm allergic to hydrocodone. Now there's only one I can take. Now let me think. Now it starts with a P, O, oxycodone. Yeah, that's it. And these are the ones that have multiple organs. Somebody that's had a history of pancreatitis, pneumonia, pretty much you're looking at an alcoholic. If they list that, they've had past history of that, multiple pneumonias, multiple pancreatitis, hepatitis, asymptomatic swelling of the parotid gland. And these are the ones that have a greater interest in what you're going to prescribe for them than what you're going to do. Well, you're going to give me some really good drugs. Can I get some really good pain medicine? Can you put me to sleep? I need some Valium. I mean, these are the ones that want nitrous to get a prophy, want Valium to get a buccal pit amalgam or composite now. And again, the potential of patients under-reporting or self-reporting of alcohol and tobacco use is great. I mean, I remember having a physician ask my father one time, well, how many drinks do you have a night, Mr. K? And he said, a couple. Patient's going to report. So the other thing too, and you ask them about that and they get angry and denial or it's you kind of know. And this is where I involve your staff, my front desk, my assistants, my hygienist may see the patient before I do initially. And, they got a pretty good idea and they'll stick a Post-it note on there with a cage questionnaire on it, or they'll pull me aside and say, we got a well-being patient in the hygiene room. And so I think the knowledge you have, well, it's kind of like, maybe the first time you went in a room to see a patient that had HIV or COVID. And so I think if you look at these patients that are addicted as medically compromised, like you would somebody that has asthma, hypertension, instead of treating them like one of them instead of one of us. And, people that are alcoholics and addicts do some awful things, and they're not nice people sometimes when they're using. But a lot of other people are just not nice people, and we just have to do the best we can and love their best and not hate their worst. And I think we need to kind of give them respect as what we can. And we need to address the addiction order. If you understand it as a medical disorder, it becomes easier to address it. Fred, I think you may have a disease of addiction. And that's like hypertension, that's like high blood pressure, that's like diabetes. Fred, it's treatable. And you just kind of do it matter of fact, like, well, Fred, I took your blood pressure today. It's 220 over 110. That's way too high for me to treat you today. I mean, it's not like you're going to go, Fred, you had too many bacon and eggs this morning. That's why your blood pressure's high. Too much salt. Ate a bag of chips. No, you just kind of, Fred, you got this. Let's do that. You need to reassure the patient that you're going to get them through this, but you're not going to give them anything that you're not going to continue to enable the addiction. This happens to me all the time. This happens at the clinic I'm going to go to tomorrow. And I think we need to, if they've got an opioid, if they're a heroin addict or something, they've got a baseline of opioids, and we're going to do something that's going to cause some noxious stimuli, like take out a tooth, do a surgical extraction, number 30. They may need a higher dose of opioids in the short term to take care of any acute pain. And So one of the things, the quandary in prescribing opioids is it's generally considered unethical to withhold opioids from somebody with an addictive disorder. Okay. However, the only absolute contraindication is if you knew the patient is going to sell the opioids. That's the only contraindication for not prescribing. So having said that, we're going to move right through that. And here is where chronic pain syndromes, like it's here, I said, fibromyalgia, chronic fatigue syndrome, restless leg, migraines, TMJ. This is where the addictive zone and the pain zone, disorder zone overlap. And a lot of these patients are on opioids. And they have a condition called hyperalgesia. And these are the patients that years ago, when they were on Oxycontin and they were on fentanyl patches and they were on hydrocodone for their breakthrough pain. And maybe you saw some of these, maybe you didn't, I did. And so what that means is if you and I bumped our finger on a disc and we would say, okay, ouch, well, give me a number, a pain number. Well, that's a 2. Where the same person with hyperalgesia, they bump their finger and it would be a 1,000. And this has to do with the way the ascending and descending dendrites in the spinal are oversensitized by the high levels of opioids. And these patients are very, very difficult to treat. And often, and I won't, I always have to get a physician consult on these to figure out how we're going to work around this, because these patients are very knowledgeable of their pain, very knowledgeable of their pharmacology, and they're very difficult to treat. And, these people have a lot of experience on opioids, high doses of opioids, and some of them function rather well. They are dependent on it. You take it away from them and they don't do well. And some of these people actually turn to heroin because a lot of their pain doctors have withdrawn these opioids from them. So very difficult to manage these, and requires, in my opinion, consultation with a physician. All right, how about the oral systemic link now? If you ever want to see that, that's meth mouth right there. And I want you to notice the dry leathery decay, the white frothy plaque there. Okay, that's meth mouth. That's opioid mouth. Now, you notice the difference between the two caries? The shiny Hershey bar, okay, that's rampant dental decay from the dry mouth, but opioid-induced nausea, if you look up, heroin patients on the nod, you often see them, with vomitus on their shirt. They regurgitate a lot when they pass out. I mean, that's how Janis Joplin died. This is Bill Kane. I think the stomach content, the hydrosulfuric acid of the stomach comes up and kind of polishes that dry leathery decay, shines it up a little bit, kind of like you see patients with bulimia, how the stomach acid erodes the lingual surface of the teeth and it's kind of shiny. That's my I call it opioid mouth. I'll see that tomorrow in my clinic, and you see that in your patients that come in, and meth mouth still out there, methamphetamine still out there. It's very readily available. They're not cooking it, making it labs anymore, but it's still very much out there. And again, so oral systemically, if you got a patient that's using drugs, whatever dental treatment you're going to do for them isn't going to last long. And I think this is another quandary that I think we as dentists need to think about is, where are we? We don't have somebody give us an signed informed consent one under nitrous or they're under IV. Are these patients actually capable of making this? And this is very difficult. This is thought provoking. And I think you can argue this both ways and be right. Should you treat patients that are intoxicated? I tend not to. Do I probably treat some that are intoxicated? I don't know are intoxicated. Well, not as much as I used to anymore. And here you go. We're dentists. We kind of look. We know we're in dental hygienists. The oral status of patients with active disease is they're neglected. Depending on the severity and the duration of the disease, in early stages they may look like a normal patient. In moderate later diseases, they've let things go. These are the ones maybe you did a bunch of restorative dentistry on, or you saw them as a regular hygiene patient for years, and all of a sudden they come in and their mouth just looks like a train wreck. And so this is the active disease. And there isn't any simple answer in treating these folks. It requires an accurate diagnosis, a physician consult sometimes, antibiotic prophylaxis for patients that are IV drug users, so you don't evoke a subacute bacterial endocarditis. And they take longer to treat and they're more difficult. And, this is also the one that may get referred to the oral surgeon. And they're unpredictable, and they may create their own dental pathology. I have had that happen. They don't keep their appointments. They have really exaggerated fears or anxieties. But if you're looking at a patient and, the first thing they want to say, well, my mouth's in such terrible shape because that really horrible dentist in the Army, or I had a horrible dentist, or my parents were horrible, or, it's not my fault. If they're singing that song, it's not my fault. Yeah, that's a giveaway that you've got a patient, maybe an active disease. Now, if you got one in recovery, again, it's accurate diagnosis, determine the patient's status in recovery, and you've got to have a pretty good knowledge of relapse recovery, because a patient in early recovery with dental pain is a relapse looking for a place to happen. And I think you need to break a HIPAA law, or not break a HIPAA law. In your HIPAA consent, have these patients in recovery, if they're willing to, give you the permission to talk to their AA sponsor, their counselor, somebody that they're be accountable for. And I think you need to give them immediate relief of pain, which is, dentists, we can do with local anesthetic. And I think treatment time may be longer. And again, I can't tell you how many patients I've treated over the years that recovering alcoholics, recovering addicts with not a whole lot of sobriety, not a whole lot of, they call it clean time, and have a toothache and they go right back to the drug of choice to stop the pain. One of my favorite things is, when they say, well, what are you going to give me for pain? I said, well, when I get you out of pain, you're not going to be in pain anymore. And the pain you had in your addiction and your alcoholism is far greater than the pain you're going to have from little postoperative pain from what I'm going to do for you. And quite honestly, that's where you put off the distal angular impactions till they've been sober for a couple years. And I think you need to have a good understanding, how are they doing this through AA, NA, through one of the faith-based? Do they have an accountability partner? Do they have a sponsor? If they're recovering without some sort of support of a recovery program, or just beginning a program with no outside help, they're a relapse looking for a place to happen. Now, here's something that's really kind of controversial now. This is a medically assisted treatment. This is where, give the patient naltrexone, or give the patient a camphocyte or Suboxone. Suboxone is what they're giving people that are on opioids now to keep them, so they're not shooting heroin anymore, breaking into garages and stealing stuff. They're on Suboxone. And yes, medically assisted treatment works, and they may or may not be involved in a support group. If they're not involved, they need to be. And I think I'm going to go through that kind of quickly. The drugs there are buprenorphine, Suboxone, methadone, naltrexone. And when they're on Suboxone, you can't use opioids. You got to stop. If you're going to use an opioid, you got to stop. And I would not stop the opioids. And so it's time for me to tell you a story. I had a patient that I'd seen for about 15 years, and she was one of those patients come and get her teeth cleaned or get a class 3 composite on number 7. And she called up and said, I've got all I need pain pills. I need pain pills. And she was kind of off the, very difficult, very histrionic. And we sort of parted company. And I didn't see this lady again for about 15 years. And she came in and she didn't look good. And by this time, she had only 6 upper anterior teeth, and she'd been somewhere a couple of days before, and they were planning to do immediate denture on this lady because she lost all her upper posterior teeth. Well, she came in and we discussed everything, and she didn't, on the health history, she denied she was taking drugs. She denied any alcoholism. Just said, life's been hard. Okay. So I prescribed some penicillin. I prescribed a few, I think I gave her 10 hydrocodone. We took the impression for the immediate denture. And the pharmacy calls up and says, "Did you know this patient is on Suboxone?" Nope. She didn't tell me. So we call the patient, have her come back in. And I put her in a consult room and I sit her down and I said, "Oh, say, Jeannie, you didn't tell me about this." I said, "I got to know this if I'm going to take care of you. You got to tell me what's going on." "Oh, yeah. I was on heroin, blah, 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 blah." I've been clean now for about 3 weeks and I'm on this wonderful drug, Suboxone. Well, I called the provider that had her on it, and we decided we're going to stop the Suboxone, take out the 6 teeth, which came out with a 2x2 basically. And I gave her, I think, 12 or 16 hydrocodone. She never came back. I was the only immediate denture patient in 41 years. I put the denture in, she never came back. And a week later, I found out this patient went back out, was on heroin again. So I find now if a patient is on Suboxone, you need to probably leave them on Suboxone, heighten their dose of, and now they're on Subuclade, which is a time-release injectable drug that works well. But here's what I'm saying. If you got a patient on Suboxone, what you should do is talk to the provider that's got them on a Suboxone and see if you could increase using Subutex, which doesn't have the naloxone in it, and use that as an analgesic, and then use ibuprofen and Tylenol. That seems to work really well. And it's worked really well for me in my practice. And I treat a bunch of these folks like that. And I really got burned on that one, putting her back on an opioid. So I think it's really kind of pie in the sky to think you're going to take someone off Suboxone, put them on a drug of choice, and expect them to go back off of it without a fight. So that's just Bill Kane's opinion. And this is a great management of this Suboxone from the University of Michigan, and basically talks about what we're using increased doses of buprenorphine for the analgesia effect. And so I think one of the biggest questions I get from dentists that know that I treat it, should I give nitrous oxide to a patient that's a recovering alcoholic? And I always say no. Because it can light up the brain receptors again and give them a hot brain, and not a good idea. I've seen this happen. I've had reports of this happening, and so I don't. Propanolol was used. They use that in actors for stage fright. I've used that with mixed. So I don't know, maybe more of a placebo. It's not considered mood altering, but it's maybe lower their blood pressure and give them that peaceful, easy feeling to get them through. But I think the thing here is just reassure the patient, try to get through it as quick as you can. Give profound anesthesia. We can do that now with that on-site, that buffering local anesthetic. That stuff's wonderful. And then you obtain profound local anesthesia where you're using intraosseous, use interligamentary. And at the end of the visit, give them a long-term, bupivacaine, a Marcaine injection. Keep them numb forever for a long time. Now, there's some stuff now in oral surgery where they're using bupivacaine and buprenorphine. I think for us general dentists, that's probably not something we're going to use. And we're nearing the end here. There's been anecdotal evidence of recovering alcoholics and addicts are difficult to numb. And, anybody that's practiced dentistry longer than dental school knows some patients can numb very easily and others not so easily. And so get them numb, keep them numb. Just slow down, take it easy. Maybe do half as much treatment as you think you would do it with a patient, and just pick something on the maxillary arch. They're going to be numb up there. Get that done, and just kind of keep building on that. And just say no to prescribing when patients have acute pain is unethical. And I think when we prescribe drugs, we need to discuss the pros and cons, of risk and benefits. We need to consult the the patient's physician. We need to encourage them to intensify their recovery network. We need to have them seek medical attention if the relapse occurs. And here's a list of drugs that we really need to watch. And recovering alcoholics and addicts know they can get a pretty good buzz with Benadryl and some of the dextromethorphan cough medicines that you can buy over the counter at the pharmacy. So a lot of these decongestants and a lot of these anesthetics and antihistamines are mood altering. And for an addict in recovery, mood altering is not good. And I think for patients with substance use disorders, we need to consider not use a drug of choice. If we have that trapepenadol, which is a long-acting oxycodone, less abuse potential, but it still scares me a little bit. Use medication with lower street value. Avoid self-administration and case-by-case basis. What's our best pain reliever right now? Well, the research shows 1,000 milligrams of acetaminophen, 400 milligrams of ibuprofen, Q6 for 36 to 48 hours. I've been using this in my practice since 2010, since that first conference in Tufts, and I do very well with it. Over the road truckers, I tell them, hey, Fred, I can't prescribe hydrocodone, maybe drive that big rig up and down the road. This is the best thing out there. I think, this is very similar. It doesn't have platelet aggregation, rapid onset. It's very safe in the short run. And this study put out by Paul Moore and Elliot Hirsch, who are the DMD PhDs in my Tufts episode. 4,000 people, they're doing third molar extractions, and they found this equivalent, if not better than 5 milligrams of hydrocodone every 6 hours without the side effects. And we know the difference between, NSAIDs and opioids. We're using a lot more. I mean, some people like to use Aleve or 800 milligram prescription ibuprofen. Your preference as a dentist as what you're going to prescribe for your patients. Here's something new and different out there. This is Exparsol, and it's oral surgeons are using this, and they're giving it infiltration after they do bilateral third molars. I think it's a really good drug to keep pain down, particularly on patients in recovery. If you have a general practice where you're doing a lot of surgery, it's something you might need to look into. The bad part of it is it's quite expensive, so that may be limiting to some patients. So, the oral surgeons that are using this that I have sent patients to, patients just rave about it. Well, I've been numb, you're kind of numb, but I really, all I took was a couple Tylenol, a couple ibuprofen, and I did fine. And this is not for nerve blocks, it's just for infiltration. I've not used it personally. The game changer that hasn't come out yet is these kappa opioid receptor agonist. This is kind of like the old Talwin drug, the pentazocine, which was an agonist, which I kind of hated they took that off the market because that worked really well. And it should be coming out here fairly soon. Here's something, abuse potential of gabapentin in general dentistry. Well, if you would have told me people are going to abuse gabapentin, I would have said no way, but the kids call them Johnnies, and they get them from grandma and grandpa that are on chronic pain, and apparently they get a high from them. So patients, your younger patients, that may be something that they're using. And I think just as we wrap this up, treating these patients, good local anesthesia, use a pre-op NSAID. Before prescribing an opioid, consider a physician consult in patients that you suspect may be at risk. And then, consider an agonist, antagonist, analgesic, and that was back for when the tall one was going on and when this kappa 4 is coming out. So, do you treat or refer? And important to pain control for emergency, immediate relief, get them numb, get the tooth out, do a pulpectomy, do a pulpotomy, open the tooth up, get the tooth out if you can, get the patient numb, get them on antibiotics, bring them back. And if the patients are in recovery, you got to tiptoe through the tulips. Okay, I finished my talk, and I'll be happy to answer any questions that are out there.
So if you want to put your questions in chat, we'd be glad to take a stab at them. I realize people are probably needing to drop off. So while you're thinking about questions, you are getting some compliments, Dr. Kane, in chat. The CE code, for those of you wanting CEs, is MCOH25. I've put that in chat, and as well as the survey link. You would have gotten an email 15-20 minutes ago, I believe, that gave you the survey link, but you'll need the CE code MCOH25. So again, we'd like to have any questions that anyone would like to ask. Of course, Dr. Kane, you were extremely thorough in your presentation, so you may have gotten people to the point where they don't have questions, but if you do, please go ahead and pop it in chat, and we'll be glad to take a run at it.
And there's my email and my cell phone. If you have any questions, you want to direct them to me based on what I've got on there too, that's fine.
Yes, and I have copied that contact information into chat, folks, too. Here is a question.
Is there something in the chat, Gary?
Yeah, something just showed up. Patients who cannot take NSAIDs, what do you prescribe for pain?
Well, your patient in recovery, patient in active disease, or just patients in general. That's a tough one because of kidney disease and so forth. You're limited to your acetaminophen and your your opioids. That's kind of the long and the short of it, I suppose.
Yeah, they clarified they meant that in general, and it sounds like you've answered the question. And then Dr. Deaton, Bill, in your experience, what is your success at confronting a suspected drug-dependent person?
My success? You mean in the office?
I think that's what he's saying. Yeah, and confronting a suspected drug-dependent person.
Well, mine is probably higher. I would say at best 50% first try. But also that's probably high, but with my background as a recovering individual, I'll break anonymity and, just that transparency, and that seems to help. But again, depending on their denial, not good. Now, I'm 100% if somebody's behind bars. Okay. But Dr. Deaton, you remember when I was well-being and confronting dentists, if a dentist was behind the bars for a DUI, that was 100%. But confronting a dentist might have been 50, 60% first time. But then again, it takes sometimes more than one try, more than one attempt. So let me say that, and it is difficult. And again, when you are rejected and when they tell you no, or they tell you to go take a hike, it's kind of hard to want to do that again, especially if they burned you really bad. So that's why I think it's important to involve your staff, and maybe between the staff, there's some staff member that maybe the assistant overheard me or the hygienist overheard me do that intervention, and maybe the next time they're in, if they come back and they're not mad at me, maybe they have another kind of foot in the door. So my question there is, don't give up. Don't give up, because you're probably not going to get a go. Well, and oftentimes too, you tell your patient you need to go see their primary care provider about their hypertension. Do they go all the time? No.
Dr. Deaton says, great answer. Any other questions for Dr. Kane while we still have him on here? I am not seeing additional questions. And you have his contact information, and we will be posting the recording. And so you'll be able to go through this presentation again. We also should be able to put a copy of the slides out and make those available to you in addition. we will try to get the slides out fairly quickly so that you can access them. So I not seeing other questions, but you are getting additional compliments. I think we can probably call it quits. I want to thank you all for being here for this very important presentation. I think Dr. Kane, you did an outstanding job, and it's really good to get this information in front of people because as you stressed in the presentation, this is not an unusual occurrence to be interacting with people that are having either issues themselves or have family members or friends who have an addictive disorder. So it's very, very important to be aware of this and aware of the world that you're stepping into. I want to thank Department of Health and Senior Services Office of Dental Health again for sponsoring this and making this possible. And with that, I think, thank you, Dr. Kane, and we will let you all go to enjoy your afternoon. Thank you very much and have a great one.